Good morning, Obi. Can you hear me okay? Hi, Roz.
Good morning.
Morning, can you hear me okay?
Yes, I can.
Excellent. Benjamin, good to see you. I think Obi, do you have your mic on?
Yes. Can you
Okay,
hear me now?
I can hear you now. Yes.
Okay.
Okay. Wonderful. Roz, who else is going to be coming on?
We had 15 registered, so there might be a few more people coming.
Okay, good. So you want me to do the introduction of Obi?
Yes, please.
Okay. All right. I'll let you begin anyway, right? And then we can
Sure.
just give a little background there, and then we can go right into Obi's talk.
Sure. So welcome everybody to our keynote with our distinguished speaker on the subject of global health and security, which I know is something we all really care about. So this is an event of the World Universities Network in partnership with the Canadian Defence and Security Network. We're welcoming people from all over the world today, and so we're really excited to hear this talk by our distinguished guest. So I'm going to turn it over to W. Knight to do the introduction.
Great, thank you very much, Rosalind. Um, I've known Obi Aginam for many, many years, and he's held a number of senior positions within the United Nations. First as senior research fellow and chief of the International Cooperation and Development program at the United Nations University in Tokyo for 2007 to 2013. I was very fortunate to be able to be invited by him to take part in a number of programs there, including giving lectures to students at the United Nations University in Tokyo. Um, Obi has been the Deputy Director and the Head of Governance of Global Health at the United Nations University International Institute for Global Health in Kuala Lumpur, in Malaysia in 2013 and 2019. Currently, he's Principal Research Fellow at the United Nations University, Adjunct Research Professor of Law and Legal Studies at Carleton University in Ottawa, Visiting Research Fellow at the United Nations University Institute on Comparative Regional Integration Studies in Belgium. He was tenured Associate Professor of Law at Carleton University before he gave that job up to go to the United Nations University in Tokyo. He has been a global health leadership officer for the World Health Organization, and this is one of the reasons why we have him here today to give this talk, because he has a very close connection with the World Health Organization, and therefore has been following very closely the developments in terms of the pandemic, but not just the COVID-19 pandemic, other pandemics as well that I think we have to be concerned about. Um, Dr. Aginam has served as a consultant for the Food and Agricultural Organization of the United Nations on trade and food safety and security, involving missions to Bangladesh and Laos. He was a member of the United Nations International Agency Task Force on Non-communicable diseases in 2014-2019, and a visiting professor at the University for Peace in Costa Rica, and the universities and various universities in Italy, South Africa, and Japan. He serves on the editorial board of the Global Health Governance, the scholarly journal for a new health security paradigm. And Dr. Aginam holds a PhD from the University of British Columbia in Vancouver. He's the author of Global Health Governance, International Law, and Public Health in a Divided World. So it gives me great pleasure to be able to introduce Obi Aginam to you today, and I look forward to hearing what he has to say about global health security. Go ahead, Obi.
Thank you very much, Andy. That was very generous introduction. When I think about couple of days ago, when Andy and I were talking about this, he had extended an invitation to me to give this keynote, and he asked me to look at some of the connections that have been made between health and human security. It's something that it does quite a lot of voluminous literature covering all of those linkages. But in practice, we continue to see a whole lot of gaps and deficits in the norms and regulations and treaties, on all of that. So that's what I think I would like to do, to step back a bit, look at, how the literature and some of those developments unfolded and where we are today in the context of emerging and re-emerging infectious diseases. I would like to share just a second. I'm trying to share my slides.
Okay.
Just 1 second. Okay.
Yep. Good to see it.
Can you see it now?
Yep. Mm-hmm.
Okay. It was a bit okay. I just need to. Okay. Sorry about that. Sometimes technology. So you can see the slides, right?
Yep. Mm-hmm.
Okay. Yeah. So yeah, in terms of securitizing disease in the international system, we all know, the essential characteristics of the international system itself. What we call the Westphalian system, which is now over 300 years. Founded on the Peace of Westphalia, nation states being the dominant actors in the international system. So threats to the geopolitical territories of nation states have dominated, global security discourses within and outside the UN system, dating 350 years back since the Peace of Westphalia. So this has been the dominant trend in international relations and security scholarship and practice. So the concept of human security emerged, as we all know, at the end of Cold War, the decline in interstate conflicts. It was thought, at that time that we were, we would witness more intrastate, conflicts as opposed to interstate, conflicts. And the UNDP capitalized on this in 1994, to develop that notion of human security, move it away, move the paradigm, shift the paradigm a bit, from focus on the threat to the geopolitical boundaries of a state, to safety from chronic threats like hunger, food, disease, repression, and all of that. So there are, various categories, of from the work that the Human Development Reports of 1994 that the UNDP did. Various categories: economic security, community security, food security, health security, environmental security, and all of that. This was kind of criticized, initially by the hardcore security scholars and practitioners on the basis that everything, is not just security. I mean, they're not saying that these things are not important: health, education, food, and all of that, water, for instance. But if you lump all of this into the security discourse, you are devaluing, the value of security. That was the dominant argument of that school of thought. But continuing from 1994, the Commission on Human Security picked up, from the UNDP work, and the Commission published this report in the mid-1990s, describing human security as the vital core of all human lives in ways that enhance human freedoms and human fulfillment. So it's not just security; human security doesn't just embrace the absence of violent conflicts, wars and conflicts, between states. It has to encompass, human rights, good governance, access to education and healthcare, and all of that. So that's so from the mid-1990s until now, this kind of tension between human security and state security, has dominated most of the security, discourses. So in the context of what has been written, the work that has been done in global health, there are quite, a lot of fascinating, perspectives that teased out very, very nicely, the impact of, even in the context of state security, the impact of, microbes, during wars and battles, historically, that, microbes have actually done, killed more soldiers in wars than bullets, for instance. Going back to, say, for instance, Hans Zinser, who argued that throughout human history, soldiers have really won wars. Microbes have. The epidemics get the blame for defeat, and the generals the credit for victory. In the same vein, I mean, the past, one of the past director generals of WHO, Grohan Brundtland, making the same argument, argued that, throughout history, we've seen the deadly combinations of war and disease having accounted for a major proportion of human suffering and death. The generals of previous centuries knew that disease was a bigger enemy than the army they would face across the battlefield. So these are some of the perspectives that tease out, historically, in the context of state security. If when two or more states are fighting or in war, the impact of microbes of disease on in those contexts. If we step back a bit in history, it's always good to step back so that we know where we are coming from. Because if we don't do that, we don't know where we're headed. So if you look at these historical perspectives, McNeil, for instance, argued in that famous work he published in 1976 that infectious diseases, which antedated the emergence of humanity, will last as long as humanity itself, and will surely remain as one of the fundamental determinants of human history. It's now very well accepted that, throughout recorded history, infectious diseases have killed more people than wars and conflicts. Plague devastated the city of Athens during the Peloponnesian War. That was the very first recorded history of epidemic. If you look at the work of Thucydides. Fast forward to 14th century, the Black Death, bubonic plague that killed a third of Europeans. the Justinian plague that led to the collapse of the Roman Empire. In the 16th and 17th centuries, smallpox, measles, influenza, other diseases decimating the Native American populations, the native populations in North America, when they had the earliest contacts, with the European forces. And this led to the collapse of the famous, the Aztec and the Incan empires. 1776, American War of Independence. Smallpox was the single factor that prevented the American forces from capturing Canada, then the British North America. 1918 to 1919, more than 20 million deaths as a result of the global swine flu, the influenza epidemic of that year. So, so in today's world, we deal with knowing where we're coming from now, the impact of diseases on mortalities and lives. We're in today's world, we deal with emerging and reimagined infectious diseases. Okay, defined as the newly emerging ones are those whose incidence in humans has increased in the past 2 decades or so, or threatens to increase in the near future. And then we have a set of diseases that have been controlled, that are now, up to a point where there was a significant decline, but there's now new incidents of such diseases. So the newly emerging ones, there's a long list. Some of the studies done by WHO and the US CDC. There are more than 100 diseases that fit into this category. Either they are newly emerging or they are re-emerging ones after decades of significant decline. So so in the context of the globalization of public health, the world that we live in, the interdependent world, just to put it much more provocatively, infectious diseases do not carry national passports. We've seen that with COVID, with the re-emerging or newly emerging diseases of recent times. They don't respect the national boundaries of states, of countries. They travel almost as fast as a jet. Okay, something happens in a rural village in Africa or somewhere in Asia. It's a matter of time, before it appears in North America or Europe. Okay, so they travel, almost as fast as a jet. State sovereignty is an alien concept in the microbial world. So, in the context of all of this, that has led to what some scholars, call the microbial unification of humanity. We are all immersed in the same gene pool. Okay, there are no more health sanctuaries anywhere. And Brundtland puts it in context, for instance, when she argued that in an interdependent world, bacteria and viruses travel almost as fast as email and financial flows. And this is just a fact of globalization that has connected, the most rural, capitals of the world, for instance, Bujumbura, capital of Burundi, in East Africa, a tiny country in East Africa. Most people don't even know where Burundi is or where Bujumbura is. And you look at Bombay, the booming city in India, Bangkok to Boston. All of these cities, are all connected because of the speed of the travel of viruses and bacteria in an interconnected world. So with globalization or with global interdependence, a single microbial sea now washes all of humanity. There are no more, health sanctuaries. We've seen that very aptly with, with COVID, which we still, live with. So one of the factors, there are so many factors, but because of the interest of time, but one of the factors that drive this is global travel. Okay, the surge in global travel is unparalleled in history. In 1993, it is estimated that 500 million people crossed international borders on board the aircraft alone. Okay, excluding land crossings. If you look at the land border between United States and Canada, one of the longest borders in the world, if not the longest. You look at the volume of people that cross, both those boundaries every single day in 24 hours. Okay, either people going to work or going for shopping or tourism or whatever or vacation. So this 500 million people are people that crossed international borders on board the aircraft alone. And the UN World Tourism Organization estimates that 1 billion tourists traveled internationally in 2012. That's 10 years ago. And they estimate that this will hit 1.8 billion in 2030, averaging 5 billion people crossing international borders every single day. So travel contributed to the transnational spread of Ebola in Africa, SARS, TB, influenza, plague, cholera, Ebola, COVID. If you look at all of these, each of these, and do an analysis, you see that, of course, travel contributed, for the spread of each of them. People on the move, okay? Refugees and people are fleeing conflicts. Some people are traveling for leisure or for vacation. There are land crossings on board, the train, by road, and migrants also who are going from one place to another in search of economic opportunities. So there's a huge volume. In the context of COVID-19, one thing that has come out, that has come out quite persuasively in terms of lessons that we've continued to learn, from COVID, is that it reinforced again, as Brundtland argues, our common humanity and shared vulnerabilities. Common humanity, shared vulnerabilities. The rapid spread of the pandemic highlights the interconnectedness of today's world, and we need a fully functioning multilateral system, that can, oversee comprehensive public health response based on the principles of justice and equity. Okay, so these are the lessons that we've continued to learn, because we're still in the pandemic. It's not yet over. It's over 2 years now, but these lessons are continuing. So when I looked at WHO data just last night, as I was preparing for this is the latest that they have on the COVID-19 dashboard. So globally, we've now seen, these are confirmed cases that are reported, over 503 million, including over 6 million deaths. In terms of vaccine doses, you see the numbers that have been administered. And these numbers are just estimates, because they are based on what is reported to WHO by the countries, or what they collect through their data collecting mechanisms. Many of these are not reported, if you think about what happens in many low and middle income countries. So let's put it in that context, that 6 million, over 6 million people have died from COVID in the past 2 years or so. And one thing that, since we're talking about security, is that about human security, the connections, is that we shouldn't look at these kinds of pandemics as a health problem. Okay, COVID is never just a health problem, but it's connected to human security, it's connected to development, it's connected to sustainability in different ways. And if you go back to the argument by Zinsa, Hans Zinsa, an American microbiologist who published that famous work in 1935, that the effects of epidemics is not just measured in mortalities alone. It's not just the number of people that have died, from the disease. Often their secondary consequences have been much more far-reaching and disorganizing than anything that could be that could have resulted from the mere numerical reduction of the population. Okay, so the argument is that we shouldn't just say, oh, 6 million people died, from COVID. So if you look at the secondary consequences of COVID and put it in the context of socioeconomic, development, in the context of human security, we will appreciate more, the impact of the pandemic. There are a couple of scholars studies that have come out recently, and that continues to come out, that have now argued very persuasively, very powerfully, that decades of progress on extreme poverty are now in reverse due to COVID. If you look at what is happening in so many low and middle income countries, the pandemic has combined with the climate crisis, and the crippling debt burdens of these countries, to lead to unprecedented increase in poverty. So the progress that is made on SDG 1, the Sustainable Development Goals 1, reduction of eradication of extreme poverty, is now being reversed in so many low and middle income countries. So so this is another way to look at it. It's not just a health issue, but a health issue that triggers or combines or conspires with climate crisis and other crises, including debt burdens, to reverse progress that has been made on eradication of extreme poverty. And the UN Secretary General Antonio Guterres captures this quite nicely when he argued that all our efforts must go towards building sustainable and resilient ways to enable us not only beat COVID, but also to tackle the climate crisis, reduce inequality, eradicate poverty and hunger. To do this, you need space for reinvestments in recovery and the SDGs, because some of the countries that are quite, some of the low and middle income countries have seen the progress they've made on poverty eradication reversed by the impact of COVID, of the pandemic. I've talked about this, but about Westphalianism. That's the world we live in. So when we talk about international global health and international security, we have to discuss that in the context of the Westphalian system. Okay, where the UN and all the UN agencies and specialized agencies like the World Health Organization, FAO, and all of that. Membership is only open to states. Okay, and these are state-centric Westphalian intergovernmental institutions. So there's nothing wrong, per se, with Westphalianism, but we've seen situations where some of the emerging global issues the classic interstate relations, are not, it's not able, to comprehensively deal with those issues. So there's a space, there's a space in governance, in global governance, that needs to be filled by, broadly speaking, non-state actors. This could be, those non-state actors can vary. This could be civil society, it could be businesses, it could be philanthropies. Okay, but we need to address some of those gaps and deficits in the governance architecture. So this has led to the state-centric versus multi-centric governance models, and this is something that comes out very strongly in the work that was done, say in the 90s by scholars like Rosner, Keohane, Nye, and a couple of them. But the most important thing, about this is that the state-centric system, operates, typically like the Westphalian institutions, the UN and the specialized agencies. So this only nation states can be, members of those institutions. The multicentric system brings together states and non-state actors. Okay, It doesn't mean that there's competition, or it doesn't always mean that there has to be competition or cooperation or interaction. So you have to look at each of these conglomerations. So it's okay for them to compete, so often they cooperate, and there has to be an interaction between them. So so we've now seen emerging some forms of public-private partnerships, and then some forms of other cooperation between states and non-state actors, just to address some of these gaps and deficits, regulatory gaps and governance deficits in the international system. So the evolving diplomacy obviously incorporates new actors, just because multilateralism is a crisis, for instance. There's now the international system is no longer populated by states as the exclusive actors. They're still dominant, but they are no longer the exclusive actors in the system. So we have two types of actors: the intergovernmental actors, exclusively for governments, and the non-governmental, that is open to civil society, private groups, philanthropies, individuals. Can also play a role as non-entrepreneurs. In such a system. The Mark Zucker and Keith, the work they did a couple of years back, looked at this and argued that the contemporary global health governance system is complicated and messy. It's comprised of numerous and varied actors with competing values, interests, and motivations. These actors could favor different strategies depending on their interests, goals, and power. And you can't fault that, because if you look at some of the emerging partnerships, you will see a conglomeration of those interests. Where you have, say, for instance, a global pharmaceutical corporation sitting on the same table, or a member of a partnership with WHO and some nation states. How do you align the interests of these big corporate actors with the interest of WHO, for instance, and the interest of nation states? So those are the kinds of analysis that we need to do. So we have this intensifying flows of people, other life forms, trade, finance, information, communication. All of these things affect global health in different ways. And Kelly Lee argues that we need, effective forms of governance, global governance, to address them, to be able to address them. David Fiedler, one of the work that he did, the first 100 years of international health diplomacy, also makes a similar argument that globalization forces individual states to cooperate with each other and to build partnerships with non-state actors, such as multinational corporations, non-governmental organizations, in order to develop effective global governance. So we note the distinction between, Fiedler's international governance, which is just intergovernmental, what governments do as probably as members of an international organization, and global governance, which is the interaction between states, international organizations, and non-state actors. So that's a very interesting distinction to draw on all of this. So this is one, I just wanted to just talk about this and the COVAX, because I know that some people were interested in talking about vaccines and vaccine equity and all of that. So this is one example. The Global Alliance for Vaccines and Immunization is one example of such public-private partnerships. Okay, it's an international organization, the Global Vaccine Alliance, bringing the public and private sectors together with the shared goal of creating equal access to new and underused vaccines for children living in the world's poorest countries. So, if a kid is born in Canada or US or in Europe or in most of the upper income middle economies, say in Asia, for instance, all of these, diphtheria, tetanus, whooping cough, polio, these are taken for granted. They have the kids are immunized, against all of this. But it will surprise you to hear that there are so many parts of the world we live in where this is not yet being done. So in the context of the SDGs, reaching those behind or those that are left further behind, we have to ask ourselves, what is the world doing if kids born anywhere in the world of 2022 cannot easily get inoculated against these diseases? So that's actually what Gavi does. It's saving children's lives and protecting people's health by increasing access to immunization in poor countries. And if you look at the governance model of Gavi, this is what you see. This is from the Gavi website. So you see a situation where a system where UN agencies and international organizations, UNICEF, WHO, World Bank, are on the board of Gavi. And then you have the research agencies, donor governments, developed industrialized countries, donor governments, vaccine manufacturers, okay, the pharmaceutical corporations, civil society, and private sector partners. So this is a very good example of such partnerships that I was talking about. If we have to address the gaps and deficits in the Westphalian system that we've inherited from 1648. Another example is the COVAX, which was set up in the context of COVID at the time when some of it's not just vaccines, but also the COVID-19 tools, the tools. You need the diagnostics, you need the therapeutics and all of that. So all of these things were in short supply, globally, especially in developing countries. So COVAX is just the vaccine pillar of that access to COVID-19 tools, the ACT accelerator. And it was set up principally by the WHO, co-led by the Coalition of Epidemic Preparedness and Innovation, CEPI. Gavi is also a part of the big partners, and UNICEF. So this was supposed to be, to create an opportunity for, to increase access to COVID-19 vaccines in low and middle income countries, in different regions. And what happened is that it's supposed to be based on, of course, voluntary donation, but also WHO can raise money, to source for these vaccines, from manufacturers, in order to stock them and, deliver them to countries in need. And countries also like Canada or US, and other countries donated vaccines into the COVAX framework. But at the end of the day, this is just a voluntary mechanism, okay? So if WHO cannot raise money to buy those vaccines, and if Canada or US doesn't want, as we saw, wanted to hoard, some of those stockpile those vaccines in order to massively vaccinate their own populations first. So this creates, inequity in different regions. So in terms of vaccine diplomacy, it was argued by the DG of WHO, Tedros Ghebreyesus, in an op-ed he published in 2021 in Foreign Policy, that the world has succumbed to what he calls vaccine nationalism, which later he called vaccine apartheid. Some people call it vaccine protectionism. There are so many names for this, but the summary of all of this is that you saw that Europe, Canada, United States, it was very, very prevalent at that time. They were stockpiling vaccines in order to vaccinate their own populations first, in order to achieve herd immunity, before helping countries in need, to have access to those vaccines. So So Tedros calls it, vaccine nationalism. And later, subsequently, when he addressed the G20, I think a few months later, used that term, vaccine apartheid, a situation where, some of the industrialized countries was stockpiling the vaccines, how to even give second doses and third doses, to achieve herd immunity when populations in different, parts of Africa and, some parts of Asia and other developing regions, are yet to have access to even, the first dose of those vaccines. Okay, so the so COVAX was very limited in terms of capitalization. As at the time that the DG of WHO wrote that piece, that op-ed, it was struggling to purchase enough doses to cover just 20% of the population of lower income countries by the end of 2021. So that's actually, in terms of equity, that's actually despicable, because what it meant was that maybe about 25% or thereabouts of the world population that live in Europe and North America had access to about 85% of available vaccines. So this leads to the concept of mutual vulnerability. You remember one of the quotes that I showed from Brundtland, the fact that we now, all of humanity is immersed in the same microbial sea. So it's illusionary to say or to think that we live in Europe or we live in Canada or US. Therefore, we are insulated. So we are mutually vulnerable. Okay. The reason why we should think seriously about human security, in terms of what we do with foreign policy or defense policy, is the fact that if we don't do that, if we don't actually think about those populations, in these developing regions of the world, we eventually be mutually vulnerable. So take the issue of mutation, that happened a couple of times, even when, say, for instance, populations in Canada and US have been fully vaccinated. If that virus mutates, say in one of the underdeveloped countries, and finds its way back here, it might actually make a mess of the protection that you have from available vaccines. So in a globalized world, we are mutually vulnerable to these emerging health issues. This was the work that Ivan Head did, 1991. I always, I go back to it all the time whenever I think about this, concept of mutual vulnerability. Still very, very, interesting to read. So in the context of global health and international security, I define, mutual vulnerability as the accumulation of all the threats posed to humans by disease and microbes in an interdependent world, and the obsolescence of traditional distinction often drawn between national and international health threats. So that distinction has been shattered by globalization, by global interdependence of societies and nations and peoples, and by some of the factors that drive all of that, including things like global travel, as I've tried to explain. So, what should we do in terms of, bringing together the defense, security, international relations, and global health scholarships? It has to happen. And one way to think about it is through an enlightened, self-interested perspective. Okay. So the reason why you do this is not because of charity, but you're doing that in order to protect yourself. Because if you don't do that, then things like mutation or even conditions of poverty and underdevelopment can breed disease that can actually, constitute a threat to populations in distant places. But this is something that whenever we raise this, whenever I've given a lot of talks in different places, to what extent should enlightened self-interest be part of foreign policy, okay, of countries? People are sympathetic to that. We talk about that. It's about empathy. It's about thinking about the other, thinking about humanity, all of humanity. But when it comes to practice, you find that we are still very, 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 very state-centric in terms of the way we think about these things. So there are so many ways, again, to think about this, and so many things have been written, about inviting self-interest, but we need to understand, that in an interconnected world, we have, it's the world basically is, as Joshua Ledenberg said, is just like a village. And when you tolerate disease in any part of the world, it's at our own peril. In the famous work that Joseph Rothblatt did on world citizenship and allegiance to humanity, he makes a similar argument, that the most important problems facing us today, the human race, are global problems. And if we have a parochial attitude toward affairs, and if we are insensitive to the destruction of the environment, lack of compassion for fellow human beings, and the insufficient imagination to see the dangers ahead, all of these things would, lead the human race to a chaotic and violent future. This is just a nice way of talking about some of those, human security, connections that we need to make, in terms of drawing the linkages between global health and international security. So the way forward, there has to be a dialogue, centered on how to build visibility of health diplomacy in foreign policy and defense, defense policies. This is extremely important. If we have things like, threat of bioterrorism or biosecurity, this is very well understood. If you talk to defense experts, security experts, they understand that. I mean, there are tons and tons of regulations and international conventions on the use of, weapons of mass destruction, for instance, chemical, biological, and nuclear, for instance. So, in terms of, from that perspective, it's very well understood. Bioterrorism, bioweapons, chemical weapons, and all of that. But looking at some of the, what I might just call the ordinary, everyday health problems that might grow and become bigger, how do we actually get the, the foreign policy, defense sectors, to sit together, and this is a task that's, it's not just this thing, but scholars have a role to play, practitioners, policy entrepreneurs on these three very important intersecting sectors. It's only when we do that that we can actually draw the type of practical and pragmatic linkages that might that might raise the visibility of health in foreign policy and defense sectors. So I think I will stop here, and maybe let's have a couple of questions if anybody has any. I'd like to thank Andy and Rosalind, for inviting me to do this. Thank you very much.
Thank you very much, Obi, and that was quite a tour de force. You've gone through quite a bit, talking about this linkage between global health security and the new ways of looking at this issue. So thank you very much for your thoughts, and we want to open it up to the entire group here. If you have any questions for Obi or comments on anything that he's said, please feel free to do so. I like the fact that he started off with history and the importance of history, and because the nature of our system of governance, I think, has to be rethought. The nature of the Westphalian system of international relations has to be rethought if we're going to be able to tackle these issues arising from pandemics and other forms of threats to our human security. So I'm opening it up to everyone to jump in at this point to ask questions or to raise issues that you see might be of importance from his lecture. And I see Simon's hand already. Simon, go ahead.
Great, thank you, Andy, and thank you, Obi, for the really interesting talk. I've got a question that I've been struggling to answer. And it takes off from where you finished in your talk, really, about the enlightened self-interest argument. And that enlightened self-interest argument for me is one that has a very compelling logic. But I guess one of the lessons that I would draw from the COVID experience is that narrative or that compelling logic really hasn't changed how governments behave, and we've consistently seen them prioritizing their own populations first, whether you want to look at vaccine distribution or whatever it might be. So what's your diagnosis for why that compelling logic of enlightened self-interest hasn't really made more progress with policymakers?
Okay, thank you, Simon. I think wearing the other hat. I was, I think 2 weeks ago, I attended one of these, sessions with the Council on Foreign Relations, and I asked this question. So I was on yesterday. I was on the other side. I asked the same guy who actually presented, what are his views about. Anyway, there are a couple of issues. First is governments all over the world are under enormous pressure from certain domestic populations. Okay, and we do know that governments is about the preoccupation is about winning elections, staying in power, and so they're always very, very attentive to what that 20%, 30%, or whatever percentage of, call them, I don't know, the right listen to. So there's always some pressure domestic, and they listen to those. Okay. And it all depends on the government in power in different countries. The US is a very good example. It all depends on who is in the White House at any particular point in time. You might see a shift in policy, and then for 8 years, there's actually it's pushed back again to this. So that's the kind of pressure that you see on governments all over the world. I was a bit disappointed by the role that the EU played, in the whole vaccine, nationalism argument. They became actually much more distant than the United States, in terms of, so we looked at all the decisions of the European Union at that time, what they said and what they did, and so they were much protectionist than the United States and than some other countries. So it's not an easy thing, but I think the only thing I find out, I can say, is that some of those governments are under enormous pressure from a certain constituency, within their countries, not to do much in terms of, those that regard. And one other way to look at it as well is the fact that, when something is happening, Ebola was a very good example. Okay, so you live in the US, or you live in Europe, or you live in Canada, and there's a way in which you hear that this was happening in Guinea or Sierra Leone or Liberia. 90% of populations in North America don't even know where these countries are. Okay, so they think, oh, it's just something, it's an African thing. I mean, it's but the moment it shows up, at the borders of these countries, you see everybody terrified. Oh, there's Ebola, somebody has tested positive for Ebola in Toronto or in Washington, D.C., or, this thing. And then you see actually, even the foreign policy circles, you see a move, to actually do something more, to address that. So we have a long way to go. And, I feel a bit frustrated because we haven't learned any lessons from, HIV, crisis, from all of these imaginary, diseases. And And at some point, before the vaccines, in the context of COVID, before the first two vaccines were, were certified, for use. If you I listened carefully to the speeches of some of the prime ministers and presidents, including, Justin Trudeau, for instance, saying that, well, if a vaccine is found, that, is going to be treated as a global public good, okay? It's going to be available to those that need it, frontline workers around the world, and, so they said these things, but eventually when the vaccines came, there was a slight change in the tone of, that, yeah, so that's quite frustrating. But we have to keep doing what we're doing, in terms of pushing for a day when, enlightened self-interest will be part of all of this.
Thank you very much. Heather, you have your hand up as well.
Kia ora from New Zealand. I have possibly a similar question to Simon, which is where you left off about visibility of health diplomacy in terms of actual policy and practice. And I wondered if you have, ideas or recommendations about the role of scholars in increasing that visibility and moving, from research and scholarship to policy.
Yeah, that's an interesting question, and I think is something that has preoccupied most of us, at least in the scholarly community. How do you translate research into policy, and how do we actually build a dialogue between scholars and the policymakers? There's no one way of doing that, and again, if you talk to, say, for instance, bureaucrats in foreign policy, there's a way in which they see scholars as, you guys don't understand, the real world, the issues. You're in the university writing books and articles, you're not in the field, you don't, so there's that dichotomy, between the so-called ivory tower and, the world of practice. But it's actually, there are some areas, for instance, where we've seen some progress, in that building that bridge between research and practice. When I was I spent some time at the UN University, and what the UNU was actually set up to do was to bridge that kind of gap, because it's essentially a think tank, to help the UN make informed decisions about emerging and re-emerging global issues. So we've seen situations where the Secretary General's office, for instance, or some of these other UN agencies would come to UNU and say, we're struggling with this. Can you give us a policy relevant perspective? Okay, can you give us a policy response? How do we, respond to this? And we've done that in so many, the UNU does that in so many different contexts. But in the context of what happens in the context of countries, for instance, if you look at Canada or UK or the United States, so how often would the State Department, for instance, reach out to academics in order to have that kind of policy dialogue? It happens, but there's no one way of doing it. But we need to strive to build these opportunities for this kind of dialogue. Where it happens, it has actually led to some practical practical achievements. But the difficult thing is how do you get this dialogue going, between those bureaucrats and the research community? Yeah, it's a big challenge, but we have to push as much as we can.
Great. I have Amitabha Sarkar, who cannot raise his hand, but wants to ask a question at this point. So can you come on in, Amitabha?
Yes, it's on now. I think he's.
Can we hear him?
We can hear him.
Go ahead, Amita.
Can you hear him? I can't.
I can't hear him. So can we go ahead then with Benjamin? I think you have your hand up as well.
Right. Thank you so much, Dr. Obi. Great to listen to you again. I'm not sure that mine is a question or a comment. In your presentation, I think you highlighted a lot of important keywords about mutual vulnerability, the fact that diseases, excuse me, don't carry passports, and that there are no health sanctuaries, our interconnectedness. I'm just so perplexed. And I think maybe you've touched on this already. My research broadly now is on the politics of origin, and particularly with regards to, I haven't really looked at it from the health perspective, but also as it affects, people. So you kind of touch on the vaccine nationalism, vaccine apartheid. And I'm here thinking about disease nationalism, right? The fact that you said, something might be happening in Guinea or Liberia, and it doesn't become a pandemic until it crosses, the border into Europe or North America. And maybe the horrible thing about that is, people get stigmatized, from certain part of the world.
Yes, yes, yeah.
Because of this whole politics of origin, where this disease is coming from. So how is it that, we can talk about mutual vulnerabilities, interconnectedness, as, diseases not carrying passport, but we are still kind of very stuck in the idea of the politics of origin, where these diseases, are coming from. And particularly, I had also wanted it to highlight on where we are with monkeypox, so many of us kind of develop anxiety, once we heard about the monkeypox, all of a sudden, some countries might be banned again. I was kind of worried about that. What would happen to students who are traveling? And families visiting each other and so on. When do we start really stripping these diseases of identity iteration? So that was a question that was just, in my mind as you were presenting. Thank you.
Yeah, no, Benjamin, you raised a very, very complex, very interesting question that doesn't go away. Every single pandemic, you see this kind of response. From different countries. Unfortunately, I think it's just the fact of the international system, because you don't have an efficient, effective enforcement, international institution, just the way you have, institutions within countries, to enforce laws or regulations. So the border closures and stigmas and all of that. I remember during the Ebola epidemic in those countries, all the countries basically shut, denied entry to people from those three countries in West Africa. It doesn't matter where, whether you've been to, assuming you have a passport of Sierra Leone and you live in Europe, and you come into Canada, for instance, you have to be questioned. You have a Sierra Leonean passport, even though you haven't been in Sierra Leone. So we see those kind of variations all the time. Most of the airlines canceled their flights to Kenya, even though Kenya didn't have any single case of Ebola, So those kind of variations. We have certain mechanisms at WHO, for instance, the international health regulations and all of that. But all that are not strong enough in terms of addressing this. And again, it's just the fact of the weakness of the international system, where you don't have effective laws and norms, to be able to enforce that, and state sovereignty also is a big question. But I agree with you. I mean, 100% that this happens a lot. It happens every single time you have, any of these pandemics cross national boundaries. So the politics of origin, is there, and that's again because of also the inequalities. The big countries, the big economies can do such things and get away with it. And then there's no. So that's just the. But it's a valid point. I take your your point on that.
Great. Amitabh, I'm not sure if you can actually.
I think he typed his.
Yeah, he typed his question. Yeah, go ahead.
Yeah, okay.
You want to read it out and then maybe respond?
Yeah, it says, I wanted to ask whether we should consider the global health security in the context of pandemic as a security paradigm in global health. If so, do you think this particular approach will deliver health from perspective of well-being and Aristotelian human flourishing attitude? This is a very big question. The first leg of the question, I think I should say yes. Whether we should consider the global health security in the context of pandemic as a security paradigm in global health. Yes, I mean that's what global health security is all about. Okay, and I think in my last slide, that's one of the things I was trying to to drive at, the fact that we still have this dichotomy between hard cost security and health induced human security concerns. So we need to think about even in the health context, okay, to this kind of paradigm shift, is necessary, in order to to have a more comprehensive grasp, understanding of the security implications of imagined health issues. Now, the other question that you raised about, if you do so, whether it will deliver health from the perspective of well-being, that's much, because health is actually not. If you look at the definition of health, not just in the WHO Constitution, but also in the statutes and laws of different countries, is much more encompassing. When you talk about something like universal health coverage, okay, it's not just when you are sick, you go and see a doctor, which also is not something that is available in most countries, depending on the system you are running. So universal health coverage means, in the definition of WHO, that everybody should have access to the healthcare that you need without suffering financial hardship. Okay, so if you put that definition in the context of what is happening, say even in the US, where you have the private system, if you don't have health insurance, how are you going to have universal health coverage? Now, the universal system that we have in Canada and most of Europe tries to create that, but there are also a lot of issues, because shortage of doctors. A lot of Canadians, millions, don't have access to this. And then there are wait times, because you have to try to cover everybody. So I did a knee this thing badly, and then I'm in pain, and I can't jump the queue. Okay, you have to wait until it is your turn. That's what. So there are you have to deal with all of this. So healthcare is quite. So it's not easy to say that once we do this paradigm shift of global health security that is going to address universal health coverage issues. And in so many other countries, for instance, you also have the tension between the public and the private. So those who are rich, can easily get, I live in Malaysia, for instance. They've done very well on universal health coverage, for everybody, for every Malaysian. But there are so many expatriates in Malaysia who, can easily get, surgeries in first-class hospitals, but the average Malaysian cannot get that, And then so you go to South Africa. So it's all different, So it's not easy to say that once we categorize, we do a paradigm shift about global health security, it's going to actually address, the well-being of individuals. in different countries. So it's a very, very complicated analysis to make, in that context.
Thank you. Obi, I have a question, I think that's linked in some ways to Simon and Heather's earlier question, but it has to do with the fact that we are living right now, I think, in an interregnum, a period of time where there's clearly a challenge to the traditional Westphalian notion of governance. And there has to be a change if we're going to make any sort of leeway on dealing with global health pandemics. But the problem, of course, is that the nation state system and the nation state as the key actors within the UN system, for example, or the World Health Organization or the FAO, they're so resistant to really embracing the notion of bringing in others into the conversation. Even, there's a problem, as we noticed recently. I think Mia Motley from Barbados pointed this out several times, the Prime Minister of Barbados. She's pointed out several times that it's very difficult for small states, for example, who are states and who are members of the United Nations system, to get into the conversation on what needs to be done about global health, climate change, and all these other issues. So there seems to be a need right now for a transition, not just in terms of a paradigm shift, because I think that paradigm shift has already started to happen in the 1980s and 90s. I remember when Keith Krause and Michael Williams were talking about the broadening and the deepening of security. I mean, there's obviously been, and that sort of coincided with UNDP's new definition of security. So there's obviously been a conceptual shift, but in terms of practical governance, there's been a problem. And the problem has to do with the fact that states are so resistant to bringing in other partners who are non-state actors. I think Rosnell makes the difference between sovereignty-bound and sovereignty-free actors. And the sovereignty-free actors don't intersect the way they should, to make sure that we deal with these problems in a sort of a real, critical way. So what do you think needs to be done at this particular point in time if we're going to move beyond simply a shift in paradigm to an actual concrete shift in actually making governance work at the global level?
Yeah, I mean that's a very interesting question, and scholars like you who have thought deeply about UN reform and all of this, are all grappling with how to deal with this. I want to say that I listen to the Prime Minister of Barbados a lot. Basically, I'll have speeches at the major events, whether it's the UN Assembly in New York or the Climate Summit in Glasgow. She's just fantastic, the way she teases out all of this. So I want to see a situation where, where on some of the global issues, whether it's climate change and small islands, for instance, I want to see a move towards maybe a coalition of like-minded states. Okay, because if you think about climate change, for instance, the small island developing states, the kind of vulnerability that they face is different from what other countries face. Okay, so if we have a situation where it's already happening, I mean, they have a kind of coalition that normally bring them together, for instance, when there's all these climate change summits. But we need to move beyond that in terms of thinking about issues 1, 2, 3. What are the issues where you stand a chance of making some practical, tangible progress if you focus on that? Okay. So this kind of coalition, I haven't seen it. I mean, they talk generally about the impact of climate change on small islands, for instance. But they've got to break down mitigation adaptation into a bit of breakdown is needed, and then you focus on a specific agenda that could listen. So that's just one example, but also there are so many other issues. For instance, in the heat of the vaccine protectionism, for instance, the African Union did something that was very practical, in terms of using the Africa Center for Disease Control and Prevention, which was a very new institution. It was new, just less than 10, 15 years ago, about less than 10 years ago. But the advocacy around that was to set up, to use the Africa CDC, aligning with, like-minded partners in different parts of the world, I think Europe and other places, to set up, centers within Africa. They were looking into the future, okay? So even post-COVID, when we have another pandemic, we should be able to produce our own vaccines, okay? Instead of waiting for, the West to, to send these things to us. So what happened in Botswana was a very big lesson, because Botswana actually, paid, for vaccines to be delivered to them. But that was delayed, because, Europe was playing games. They wanted to give those vaccines in Europe, so it's not about money, it's not about poverty. Botswana had money, they paid, and they were waiting. They were put on the waiting list, until Omicron came, and then even the mutation, the way the discourse around that, the fact that, the mutation was in South Africa, when actually the Netherlands have actually said that, they noticed this weeks before, the mutation in South Africa. And that led to what Benjamin said, travel apartheid, closure of borders, and, Canada announced closure of, to about, 10, 15 African countries, because they are seen as, it was temporary anyway, but, they announced it. Nobody from those countries would, even though Omicron actually was in Europe, was in Netherlands, So these are all complicated set of items, but I want to see, that kind of coalition, towards those kind of issues.
Yeah.
Mhm. So on behalf of the World Universities Network and the Canadian Defence and Security Network, let me express our sincere thanks to Dr. Aginam for spending this time with us today. Very thought-provoking, very interesting discussion. Thank you so much for all of our participants and for your wonderful questions. And we look forward to connecting with all of you soon around these issues. Thank you again.
Thank you.
Thank you, Obi.
Thank you.